Good morning. I'd like to welcome you all to our workshop session, Surviving and Thriving as a Small CF Center. My name is Geraldine Wonderly, and I am the pediatric nurse coordinator at the Medical University of South Carolina. I'm also the program coordinator, registry coordinator, newborn screen coordinator, which is how it goes at small centers. I've been a nurse at MUSC for about 25 years, and I am so happy that I found my way to the CF program in 2021. My co-chair, hang on, let me just remind everybody that we have no disclosures, and this is a workshop session, so it's 2 hours, abstract focused. Each presentation is 15 minutes, immediately followed by 8 minutes for Q&A. So use the app if you'd like to send in questions, or you can get up and go to the mics. And it will be a recorded session. My co-chair is Michelle Prater. She's been working with CF patients since 1992. In 2000, she joined the pulmonary division at McLean Children's Baylor Scott and White in Temple, Texas. She's a nurse practitioner, and in 2003, she became the CF nurse practitioner and the program coordinator. Once again, how it goes with small centers. Michelle just reached her 36th year of service at McLean. Little fun facts, Michelle loves running, and my favorite fitness sport right now is boxing. All right, I'm gonna hand it over to Michelle.
Didn't know that, Geraldine. We've been more careful around you. Hello, everyone. Okay, for the past couple of years, some of you may have come to a roundtable that I had with the same title of this session. Last year, a second table had to be dragged up. And so the leaders at the conference asked if I would bring this topic to a larger forum. So here we are today in this larger forum. I've been the clinic coordinator at my center for 25 years now. We were once an affiliate of UT Southwestern. And in 2018, the CF Foundation gave us the opportunity to be a core center. And so at that time, we fulfilled everything. But I've seen firsthand the struggles of trying to be a small CF center with keeping up with a busy pulmonology practice. And as she said, wearing multiple hats. And sometimes it's just not pretty when you're trying to do that as a small center. So we get it. As we sorted through the abstracts, because this is an abstract-driven presentation, we decided to define a small center as having less than 100 patients. Now, some of you sitting here today may have more. We have 3 abstracts being presented this morning highlighting the work that small centers have done. So if you are from a small center, take heart. You can do some of this work. And we also have 2 additional sessions tackling unique small center problems with creative strategies. There we go, that's our learning objectives. If you're from a center less than 100 people, or patients, raise your hand. Okay. Leave your hand up if you are a core center. Okay. All right, thank you. Geraldine's going to introduce our first speaker.
Okay. Our first speakers, it's a duo. Lainey Vernon is the lead CF nurse at UW Health Kids in Madison, Wisconsin. She's been with the CF program for over 5 years and is active in quality improvement. In fact, this year she was nominated for the Nurse Excellence Award for her dedication to her patients and the Cystic Fibrosis program. As a result of the project they're going to present, Lainey will be transitioning to her new role as the Pediatric CF Program Coordinator in mid-December. Beth Northey has been a registered nurse at the University of Wisconsin Health Kids in Madison since 2016. In 2021, she transitioned to outpatient pediatric pulmonary clinic. She is a certified pediatric nurse and a certified asthma educator. Beth is passionate about supporting kids and teens with CF and helping them live full and healthy lives. And a little fun fact, Beth has a background as a swimmer, and Lainey says, great, because I can't swim well.
Good morning, I'm Lainey Vernon.
And I'm Beth Northey. As it was mentioned, we are both registered nurses with UW Health, and we have no relationships to disclose with this presentation.
Today we'll be sharing a summary of our pediatric CF program, as well as discussing a recent project we completed that centered on the addition of outpatient pharmacy services to our CF team and how that reduced nursing time spent on medication access challenges.
We are a part of the UW Health Pediatric Cystic Fibrosis program. We're based in Madison, Wisconsin, and located within the American Family Children's Hospital. UW Health also has an adult CF program with their own team, and together we make up the UW Health Cystic Fibrosis Center. For our pediatric program breakdown, we have 88 patients with cystic fibrosis who range in age from newborns to 21, and we have 77 of our patients on highly effective modulator therapy.
As Beth mentioned, we are located in Madison, Wisconsin, but we serve the greater Madison area as well as northern Illinois. We have 3 affiliate centers that serve their own patient populations in Marshfield, Green Bay, and La Crosse.
Our CF multidisciplinary team includes 2 nurse practitioners, 2 physicians, 4 registered nurses, a medical assistant, a rotating respiratory therapist and pulmonary function technician, a social worker, a mental health coordinator, a dietitian, 3 research coordinators, and in January of 2023, we added to our team a clinical pharmacist and a pharmacy technician.
We have several CF team meetings. The first of those is our quality improvement team. We identify and enable best practices to improve overall function of the CF team and patient care. Then we have our CF pharmacy quality improvement team, which we'll talk about more in detail later in the presentation. Moving on to our CF demographic and database meetings, we review upcoming clinic patients and identify their needs ahead of visits. And then we also ensure any recommended CF care guidelines are followed and annual requirements are met. The last of our meetings is our full CF center meetings, which include all pediatric and adult CF team members. We review any upcoming patients that are transitioning from our peds to adult program, discuss any overall team changes, and then review upcoming and current research studies.
For our typical clinic workflow, we primarily see our patients with CF in clinics on Mondays and Wednesdays with overflow into Fridays. Our providers are also seeing non-CF patients within the same clinics. We are located on the 2nd floor of our children's hospital in a space called the Pediatric Specialty Clinics, which consists of 22 core specialties that see patients in essentially a giant clinic setting. Each morning, every specialty is assigned a certain number of rooms to use for the day for their clinic. In terms of the clinic nurse's responsibilities, the nurse plays a key role in coordinating and managing all visits within our pulmonary clinic, both CF and non-CF. Specifically for our patients with CF, the nurse acts as a facilitator for the visit, ensuring that all members of the multidisciplinary team see the patients in a timely fashion. The nurse is typically the last person to go in and see our patients, at which point we collect our sputum culture, assist with any education and coordination of care, and then also help to schedule a next follow-up visit.
Let's talk a little bit about our nursing coverage or how we function as a nursing team. We have 1 nursing clinic for all providers. As Beth mentioned, that is not exclusive just to our CF patients. And then we have 3 remaining nurses that assist with triage, care coordination, medication management, education, and then just general clinic preparation and pre-visit planning. As far as the populations that we manage as a full pulmonary division and as a nursing team, obviously cystic fibrosis, and then technology-dependent patients, neuromuscular patients, asthma, BPD and chronic lung disease of prematurity, and interstitial lung disease. On a day-to-day basis, those 3 nurses that are not in clinic are assisting with managing all incoming phone calls and MyChart messages, communications with DMEs, schools, home nursing, refills and medication coverage tasks. We'll talk specifically about CF medication management later in the presentation. And then we also prepare orders, verify PFTs, and just confirm appropriate scheduling ahead of visits.
So switching gears, we wanted to talk through a project that began in 2022 that focused on adding pharmacy services to our CF team. Interest in this project was multifold. First was related to nursing workload. As a nursing team, we were going through various challenges in recent years with turnover and lower staffing, changes in workflow related to the pandemic, and an increase in COVID-related work. And also HEMT was being approved for additional patients during that time, which also is adding to our workload. The graphic on this slide shows a timeline of our project as it relates to HEMT. And as you can see, our pre-intervention study and the introduction of our pharmacy services occurred shortly after the first two major HEMT approvals. With HEMT being approved, we just identified an increased need for medication education and coordination, best done by medication experts. So all of this led to the creation of a project that centered on adding pharmacy services to our team, with one of the primary goals being to help decrease nursing time spent on CF medication access tasks.
As Beth pointed out in the previous graphic, our pre-intervention study was done in April of 2022. Nursing tracked 2 weeks or 10 business days of time spent on CF medication and pharmacy-related encounters or tasks. These included PA requests, issues and tracking, new medication starts, refills, and then just general pharmacy issues and prescription clarification. The 10-day total of time that outpatient nursing spent on CF medication access challenges was 290 minutes. I will note at that time we noticed the majority was spent on prior authorization encounters and troubleshooting.
This data was then used to help apply for a grant through the Cystic Fibrosis Foundation. Funding for the grant was received in late 2022 into early 2023. The grant award provides 3 years of salary support for 0.4 FTE for a doctor of pharmacy and 0.2 FTE for a pharmacy technician. There's also additional funding included in the award for travel and registration for NACFC. Pharmacy services officially joined our team on January 1st of 2023, and with the addition of our pharmacy team members, nursing began to transition appropriate CF medication access tasks over to them.
Just expanding on pharmacy services, both the role within our CF team and then outside of it. So we have our doctor of pharmacy. She has 0.4 FTE or 16 hours per week dedicated to our pediatric CF population per the grant. And then her remaining 0.6 FTE is an adult pulmonary. She did begin her role as an adult pulmonary clinical pharmacist, managing patients with CF, as well as ILD, pulmonary hypertension, asthma, and severe COPD. With the approval of the grant, she decreased her FTE with the adult team to transition to this hybrid role. Her responsibilities include advanced medication management services for pediatric CF patients and adult pulmonary patients. Then we have our pharmacy technician. She is 0.2 FTE or 8 hours per week dedicated to the pediatric CF population per the grant. And then her remaining 0.8 FTE, she functions as a medication access coordinator for our pediatric and adult specialty clinics. Her responsibilities include assisting with prior authorization needs for peds CF patients, as well as multiple other peds and adult clinics. She also helps facilitate pediatric discharges. She is crucial in facilitating communication with our specialty pharmacies for the CF patient population.
So 6 months after pharmacy services joined our team, we did a post-intervention study. So in July of 2023, nursing again tracked 2 weeks or 10 business days of time spent on CF medication and pharmacy-related tasks. The 10-day total for this period of time was 265 minutes, so an initial reduction of a mean average of 2.5 minutes per day. We did expect for this decrease to be more robust, and so we came together and identified a need for a process improvement, and we began incorporating regular CF pharmacy QI meetings to enhance communication and collaboration between our roles. Initially, these meetings occurred twice a month. Our first meetings were really centered on what types of tasks had already transitioned over to our pharmacy team members and looking at additional tasks within their scope that they could take on. Also, during these meetings, it was discovered that our nursing team had fallen back on using some previous workflows instead of delegating some tasks to our pharmacy team members, so made necessary process changes to remedy that. And really the main focus of those first meetings were to ensure that the right team members were doing the right tasks for their discipline. We do continue to meet as a group, but we've been able to space these meetings to monthly, and we really use them as a check-in and an opportunity to discuss current patients with medication issues.
2 years after pharmacy services joined our team, we did another study. So in March of 2025, nursing again tracked 2 weeks of time spent on CF medication and pharmacy-related encounters or tasks. The 10-day total at that time was 125 minutes. This was an additional reduction of a mean average of 14 minutes per day.
So just a summary of our data again. Our pre-intervention 2-week total was 290 minutes. Our 6-month post-intervention 2-week total, 265 minutes, and then our 2-year post-intervention 2-week total, 125 minutes. So the total reduction in nursing time from April 2022 to March of 2025 was a mean average of 16.5 minutes per day.
We took the data collected and used a 3-group Kruskal-Wallace comparison to compare the 3 time periods, which were T1, pre-intervention, T2, 6 months post-intervention, and T3, 2-year post-intervention. The graph on the slide illustrates this data. We did find a statistically significant difference between the 3 groups of data with a p-value of 0.0087. We then did 3 separate Wilcoxon rank sum tests for 2 group data comparisons, and it was found that T1 versus T3 was statistically significant with a p-value of 0.0246. As far as limitations of our study, we did only track for 10 days in each period. However, despite the limited number of days tracked, we were still able to see a significant drop in time from group 3 compared to group 1.
So just in conclusion, we found that the addition of outpatient pharmacy services, including a doctor of pharmacy and a pharmacy technician, significantly reduced the amount of time our outpatient nursing spent on CF medication access tasks, which then allowed our nursing team to spend more time on other patient care needs. We also found that the implementation of regular CF workgroup meetings that included nursing in addition to our pharmacy services and a physician was an effective process improvement. I do just want to take a moment to mention that we mainly discussed in this presentation how incorporating pharmacy services impacted our nursing team, but really our entire team and our patients have significantly benefited from the knowledge and expertise that they bring. Our new medication starts are smoother, our med education is more comprehensive, and our prior authorization process is more streamlined. And this has all led to improved patient care and patient and family satisfaction.
So what does this mean for us moving forward? We'd like to continue to have clinical pharmacy services on our CF team and are working on an extension of the current grant. We're also applying a similar concept to updates to our RN program coordinator role. In our current state, the program coordinator FTE is split between one of our nurse practitioners and the nursing team. But with the upcoming retirement of our lovely nurse practitioner, we're evolving and updating the pediatric program coordinator role to be a full-time RN position who will manage all aspects of CF patient care. The other thing that we're in the process of updating is moving towards more dedicated CF clinic days. We are cohorting our CF patients mainly on Mondays and Wednesdays. Just wrapping up, we appreciate the opportunity to share our project with you today and tell you a bit about our CF Center. If your center is interested in taking on a project similar to ours, our advice would be to lean on your resources and communicate and collaborate with all members of your CF team. For example, we worked really closely with our physician leader, our pharmacy team, and a statistician to execute this particular project.
Good. All right. Does anyone have questions for Lainey and Beth? And I don't see any in the app yet. Has anybody sent any through the app? Just so I know this is working. Okay.
Can you guys just talk a little bit about the application process for the grant?
Kind of. We weren't necessarily involved in the actual application process ourselves. That was mostly done by one of our former physician leaders, and then now has transitioned to our director and our pharmacy, or our pharmacist. So they would have more information about how that actual application process looks, and we'd be happy to connect you with them to get that information.
I was curious if you had looked at what nursing is currently, they still have the 123 minutes. What does that look like? Is it prior authorizations and things like that? Have they completely sent that to pharmacy? Or is it more just speaking on the phone with the family and actual communication time with the families?
I'm going to take it. That's a good question. The way that we practice, most of the calls come through the nurses. Faxes are received through the nurses. So we're really the first people who touch everything. And so most of that time was just either taking initial phone calls, going through faxes, certain refills, and then sending it off to our team members.
And I will note that prior to pharmacy services, a lot of that back-end work of actually speaking with the specialty pharmacies when we had issues with prior authorizations or they didn't receive a script was done by nursing. But since we now have our pharmacy tech who specializes in prior authorizations, she has built contacts with the specialty pharmacies and can kind of connect with them more easily and streamline that process so that we're not waiting on hold, for periods of time.
Hi, thank you for sharing your experience. Danielle Getz, CF Center Director in Buffalo. I just wondered if you, I missed how many patients you follow in your center?
Go ahead. We have 88 patients with CF that we
Okay, yeah, we're about the same size. Do you have any concerns, like especially in the current state, about continued funding of the program? That's the concern at our center. We're looking into like 430B programs and stuff.
I don't think at this current time we do. Obviously, we're always growing and evolving and making changes to make sure that we are, getting the funding that we need, but it's not something that's particularly on our radar right now that I'm aware of.
Hi, my name's Alyssa. Similar size center. As someone else said, I wear a lot of hats as a program coordinator. Do all the prior auths, all the medication access issues. So getting the pharmacist is something we're looking into. How does that work with your pharmacist technician that's doing the prior auths? Are they available Monday through Friday? And they just know that when they see a CF patient come through, they need to work on the prior auth, or how does that work?
It's a lot of just close communication with us and our pharmacy technician. Obviously, she only has a certain FTE dedicated to us, but that doesn't mean she's only available like on Tuesdays. She is pretty much available when I have questions that come up. I'll, send her a message and say, can you reach out to your contact about this? Because I'm not really sure what's going on. And she is full-time otherwise, so she's available for questions that come up and to send things to her whenever we do need to send them. Obviously, we try to prioritize things that need to be addressed right away and then understand that she has a whole nother job, so some things may take some time to get back to us on.
Great, thank you.
We're going to take some questions from the app. The first one, what method did the nurses collect time metrics? What was their time study?
Each time we would have a encounter come through that was related to one of our cystic fibrosis patients and medications, we would just start the clock and count the amount of time until that encounter was done, tally that, and then have all of the numbers come together at the end of the 2-week period for our total.
Okay. And then this is similar to maybe another question, but once the grant is dried up, what's the plan to keep these people in their positions?
Yeah, so I know we're working on an extension of the grant, but also a reason that we did this study was to kind of show our institution the need for pharmacy services, both within our CF program and then maybe just in pulmonary and other specialties as a whole. So we're trying to continue to, collect data and show that this is important work that they're doing within our specialty clinics so that when the grant does dry up, we can continue to have these funded by our institution.
Okay, we can take one more. We actually had a lot of good questions. Are you finished, and do you plan to further reduce the RN time spent on the medication aspects?
We're kind of in a transition period right now just because we're moving towards this RN program coordinator role that will take on all of kind of the incoming CF things and manage clinic. So I think that it would be a good idea to kind of see what it looks like after that transition and what the coordinator is doing as far as medication encounters versus our pharmacy team. So I definitely think there's more work to be done to make sure that we are still having the appropriate person do the appropriate work.
Okay, if your question didn't get asked, you can connect with these guys. Do you have your contact on your on the?
I think it should.
I think it is.
Yes, it should
I
be.
think it is. Okay.
You can hang around after.
Yeah,
Right.
you can hang around.
Okay.
Thank you. Okay. All right, our next presentation will be given by Dr. Noelia Bergas-Gimbernat. She is the director of the Adult Cystic Fibrosis Center in Mendoza, Argentina, and has been since 2018. Her passion for enhancing the quality of CF care in rural Argentina is evident. She is the vice president of the Mendoza CF Parents Association and a key member of the International Cystic Fibrosis Training Network, partnering with the pediatric team at the University of Alabama, Birmingham. Presenting with her is Mariana Kamsnit. She has been the nutritionist at the Adult CF Center in Mendoza since 2019. She's active in quality improvement initiatives and also with the International Cystic Fibrosis Training Network with Dr. Bergas. And these two women were so pleasant to finally meet them in person after a 2-day journey. They were full of smiles and warm hugs. So here they come.
Yes.
Hi everyone, today I will present our work. Trend training success in low result areas quality improvement training for establishing a CF center in Formosa, Argentina. To start with, a comprehensive multidisciplinary approach to chronic disease like cystic fibrosis is crucial for improving patient outcome. Treatment, advancement, and specialized CF centers have enhanced survival rates, but in Argentina, patient outcome still lag behind international standards despite the availability of generic CFTR modulators. The University of Alabama at Birmingham Pediatric CF team the International Cystic Fibrosis Training Network to improve care access in low-resource settings. In 2019, the Adult CF program at Hospital Lago Maggiore in Mendoza joined ICFTN, receiving training to establishing an effective multidisciplinary team. Lago Maggiore's success led to its participation in ICFTN's international mentoring training initiative to train other teams in Argentina. Here you can see the two teams, Lago Maggiore and Alabama. Objective. Here we present Lago Maggiore's experience of training a peer adult CF team in a small center in the province of Formosa, Argentina, to improve their functioning and care delivery fulfilling ICFTN's aim of train the trainer.
So, hi everyone. To continue what Noelia was saying, the first step of this journey was the selection. Here you can see a map of Argentina. In the circle, we have Mendoza, that is our province. And in the top right, in red, you can see the Formosa province. So, as you can see, it's far away for us. And you may ask yourself, why is these people training a team so in the other side of the country? So actually, the selection came from a need to improve their way of working. Shortly after its establishment in 2023 as a CF team, its lead physician expressed their interest in receiving training from us. Formosa is a province located in the northeast of Argentina with tropical temperatures. Its population is over 600,000 inhabitants and is a province with low resources. They have neonatal screening since 2015, and sweat tests had to be done in other provinces far or in private laboratories. So the second step was the evaluation. Before initiating this training process, different essential requirements were evaluated and met. This included demonstrated interest, safe geopolitical situation, a supportive health system, the need to implement changes, access to basic medications, strategic geographic location that covers vulnerable areas, and the availability of diagnostic services. It's important to say that the Formosa Hospital, that is called Juan Domingo Perón, is a high complexity hospital with specialized services including neonatal screening, general biochemical laboratory, bacteriology, chest CT, ventilation perfusion scan, MRI, lung ultrasound, lung laboratory, spirometry, plethysmography, TLCO, and so on. So the training finally started, and it started with meetings, obviously. We held regular video meetings, monthly or bi-monthly, between the Formosa and the Mendoza team to discuss diagnosis, pathology management of specialties, and clinical cases. And here you can see what our distance training was about. In 2023, we started holding these regular video meetings. And during this stage, we shared our journey so far. We introduced different quality improvement tools. We also emphasized the importance of an interdisciplinary team and worked on meeting organization and discussed different topics of interest to the Formosa team, and also the discussion of several clinical cases. In 2024, new professionals joined the team, and there was an increased interest and commitment. They created a WhatsApp group to enhance communication. There was more recognition by the institutional authorities, and they managed to acquire equipment and training to perform sweat tests in the hospital. So it was a great thing for them. In 2025, we finally had our benchmarking visit. This visit to the Lago Maggiore Center took place in March 2025. And during this on-site visit, the Formosa team was updated on CF care standards adapted to these local environments, such as public hospitals, basic theory and practical application of different QI methodology were taught, including PDSA cycles, process mapping, cause-effect diagrams, and so on. And here you can see their results. Currently, they have a total of 15 patients between pediatric and adult ages, both of them. And Formosa has established a strong communication with their patients by using the features of WhatsApp. The team is now tracking statistical data to inform clinical care, and in 2024, they received recognition from their institution as the Formosa CF Commission. In this table, you can see the results and improvements achieved through the training process for the Formosa team, focusing on 4 key areas: team specialties, data logging, physical space, and quality improvement. In 2023, the team included only pneumonology, pediatrics, and molecular biology, but there was no clear organization of the consultation. In 2024, they actively incorporated nutrition, kinesiology, social worker, and nursery, but still, although there were no structure of the consultation, it was still pending. And finally, in 2025, the teamwork was formally established, and they began to structure the care. Regarding data management, in 2023, there was no registration system. In 2024, they started recording patient data in Excel and started with the registration of the adult patients in the national registry that's named NACFC in Argentina. And in 2025, they improved the patient registration system. About physical space, until 2025, they have They had no common physical space to allow joint visits. And in 2025, they managed to acquire a common space for the attention of the other professionals. And concerning quality improvement, in 2023, we initiated them in quality improvement training. In 2024, they started implementing effective meetings, SWOT analysis, and clinical macrosystems work. And finally, in 2024, they advanced to formal training on quality improvement methodology and implementation. It's important to say that all these tasks mentioned were carried out with the active collaboration, supervision, and mentoring of the Lago Maggiore team.
So, to conclude, a structured training tailored to local conditions has improvement care process and set the basis for better patient care by an adult CF center in Argentina. This shows that the training model is effective even in resource-limited setting with the potential to transform cystic fibrosis care in Argentina. Here you can see both teams, Lago Maggiore and Formosa. Thank you.
Oh, questions for Dr. Bergas and Mariana? I know we have one in the app so far. I'm basically asking about patient resources, getting them vests, and modulator therapy. Can you comment on what the standard of care for modulators and airway clearance are locally, at the local level?
Be patient with our English, please. Preguntan qué recursos hay para el tratamiento con moduladores en los pacientes y la técnica de limpieza. Yes, in Argentina, in the whole country, we have a generic CFTR modulator, so it's like guaranteed for all the patients with and without a social help. I don't know. Yes, and the airway. Sí.
Así no tenemos, por ejemplo, aeróbica, pero sí tenemos.
About the health cleaning techniques, we don't have aerobica, but all the other techniques are available in all the Argentina provinces.
And is it the same that the patients get them because they have CF and that's that? You don't have to have, are they paid for by the country or?
The CFTR modulators?
No, the vest systems or the airway clearance machines.
Sí, todas estas técnicas de limpieza ven que las paga los pacientes o las obras sociales.
Yes.
Okay. Yes.
Any other questions?
I have a question.
Yeah.
Approximately how many people with CF are there in Argentina? Just a rough number in your country.
We have this registry that is NACFC, and today.
1,000.
In the registry, 1,088 patients.
Okay. And how many total centers in the country? How far do patients travel?
1,808. Okay.
How far do the patients travel to get to a CF center usually?
Yes, that's a problem, and that's why we wanted to do things like that. And I think that's one of the goals of the ICFTN network and this initiative. Pregunta que cuánto tienen que viajar los pacientes. In Formosa, for example, they usually went to Buenos Aires when they are little. In the pediatric age, they always go to Garrahan in Buenos Aires. They don't have local CF centers, so they have to travel thousand of kilometers to a CF center. And it's important that these small centers are developing, and the patients are gaining trust of these centers, and they don't have to travel anymore. We have centers like Formosa. The pediatric team is training a center in Tucumán, in San Juan, in San Luis, in other provinces, so that we can regionalize the attention.
Great. It's going to greatly enhance the care.
Trevor sent in a question that I think was mostly answered through other questions. Does Trevor agree? I think. Okay.
Said, how much of Argentina do you serve?
Yeah.
Any other CF centers in other parts of Argentina?
I think
Okay, no sé qué. Sorry?
I think.
Okay. Got that one. Oh, I see another one. It blinked again. Give us 1 second.
Oh.
Right here. Did you have any challenges implementing the new training?
Yes. The distance was one of the difficulties that we had. Another barrier maybe was that we had to continue attending our patients at the same time that we started to train another team. And we also are a small center, so it was challenging for us. And ¿qué otra barrera tuvimos? Otro desafío. This distance carry an economic barrier because the traveling is expensive. It's expensive to us to go to Formosa or to the Formosa team to come here to Mendoza. And it was also challenging to maintain their attention and their motivation through these virtual meetings. There was 2 years of only regular virtual meetings, and it was challenging to maintain the attention and the motivation. But once we finally met in person, it was great. It was so easy.
Funding. All right. Are you gentlemen from Argentina?
Yeah.
Okay, from the center. Any comments of your challenges and triumphs?
We have version 3, but we are supposed to be about 6,000 people. So there is a solution for publication. Many other very to treat the patients. They are not true VIP ones. So I probably have to bring them all of them.
Yeah.
They have the eligibility.
Okay.
We have a question at the mic.
Sorry.
Hi, I'm a social worker, and I'm just curious. I see that you have a social worker on your team. Are there programs available to help with that travel expense back and forth? And if so, is there a cap on that?
Es trabajadora social y dice que si es de trabajo, si hay un programa para ayudar a que viajen a donde tienen que ir o no.
Siempre. Nación, sí. Es decir, lo que tiene función, se hace cargo.
Yes, we have a social worker in our team, and Formosa does too. And there are some national helps to help the patient to go to their center. I don't know, for example, we in Mendoza have patients that comes from 100 kilometers away, and there are some financial help to help them to arrive. En el caso de Formosa, sí, no, sí. And with a more distance travel, also there are some helps that comes from the government.
Let's check the app one more time. No, I think we got it.
All right, thank you so much.
Thank you.
Just want to say they traveled so far, and they are definitely our longest distance travelers here today for our presentation. Okay, so I'll introduce our next speaker, Dr. Rebecca Neville. She's an associate professor of pediatrics in the Division of Pulmonary, Allergy, and Sleep Medicine at the University of Missouri School of Medicine and Children's Hospital. Her clinical and research interests center on rare and diffuse lung diseases in childhood. She's committed to advancing the understanding and treatment of pediatric pulmonary conditions through both patient care and academic scholarship. Welcome, Dr. Neville. She brought a cheering section.
Okay, good morning. I have no financial relationships or conflicts of interest to disclose related to this presentation. So this presentation outlines our journey at the University of Missouri Pediatric Cystic Fibrosis Center to initiate and accelerate quality improvement efforts. This work was really made possible through collaboration of the entire CF team, and they're all listed here as co-authors. So as we all know, quality improvement is a foundational element in any healthcare delivery system. It enables teams to fulfill their commitment to patients and families by striving for the highest standards of care. Our approach is informed by established resources, including the Cystic Fibrosis Foundation Action Guide for Care Improvement. Despite the importance of QI, our pediatric CF center lacked any active QI initiatives at the start of this process. This gap was identified as a priority during one of our CF Foundation Center site visits. For a brief overview, our center is based in Columbia, Missouri, with an outreach clinic in Springfield, Missouri, approximately 3 hours away. We serve 84 pediatric patients across a broad geographic region extending mostly central, northern, and southern Missouri, but into Arkansas and Iowa. Our multidisciplinary team includes 2 pulmonologists, a GI specialist, nurse coordinator, dietitian, respiratory therapist, social worker, pharmacist, pharmacy technician, and a physical therapist. Support for our program is a combination of CF Foundation grants and institutional resources as listed here. So historically, QI projects at our center had been completed, but then lacked sustainability. The barriers to this ongoing work were really multifactorial. These are not excuses, but really realities we faced. We are a small center with high clinical demands for all of the team members. We also had a recent transition of our CF Center coordinator. We have the geographic challenges I mentioned, and then a fragmented infrastructure complicated primarily in the last several years by the building of a new children's hospital, which was lovely, but kind of fractured our team for about 3 years. We had separate administrative offices and clinic spaces and inpatient hospital. So it really did fracture our team for multiple years.
So at the outset of this process, again, like I said, we had no ongoing QI projects in our pediatric center. And this slide is relatively empty, illustrating the absence of that structured QI and really the need for a systematic approach. So we hypothesized that initiating, even within a small CF center, a collaborative group identification of worthy goals, shared leadership, and establishment of specific processes, including team education and procedures, would provide these three major steps to grow our QI work. But what are the details to achieve this progress? So our care team included all core disciplines, and it was really this engaged and passionate team that was essential for identifying and leading the QI initiatives. Sorry. So we, we conducted a focus group to identify these worthy goals. Team members primarily focused on implementation of the newer CF Foundation guidelines, patient and family needs, and then barriers in quality care delivery experienced by the team members themselves. So we came up with a lot of ideas, and to avoid idea overload, we used an impact effort matrix to objectively prioritize our list, selecting really initially high impact, low effort for projects, as well as a couple of more intense, high impact, high effort QI works. So through this, we have identified our list of important goals, which our team was then individually motivated to address. Each team member then selected a QI project out of that list to either lead or co-lead, and this really distributed that distributed leadership model, established a way to share the burden of effort it takes to push a QI initiative forward, but it also allowed us to share successes as well. Improved communication overall, reduced duplication of work, and fostered engagement of the entire CF team. It also encouraged some accountability. So at this point, we had a CF team member empowered as the lead for each QI initiative. To make this practical, our process needed a defined infrastructure. Using resources already available at our institution, we established a recurring meeting schedule, a centralized resource repository for information, and provided education on QI methodologies like aim statements, PDSA cycles, all using existing QI experience within the team itself. Routine project reviews and collaboration of process sharing and problem solving within these scheduled meetings has been really key to maintaining momentum. So here we are, our QI program procedures are now in place, and what does this look like? So right now we have 7 active QI projects, each led by a member of our team. As you can see, these address really diverse areas of clinical care which impact our patients and families with CF. They are all still ongoing and at various points in their PDSA cycles. Okay, so our measures to describe success. How do we know that this process was successful? We identified that the number of QI projects, since we started at 0, was important. Team engagement really was another main priority, and then sustainability. So within 6 months of starting this project, we had 7 active projects. We had 100% team participation as either a lead or a co-lead on one of these QI initiatives. And we have a sustainable process for preset, regularly scheduled meetings and a central repository for those shared resources. We also, because of this, have shared responsibility and individual empowerment to improve our quality of care. So our experience demonstrated that even in a very small center, you can rapidly initiate and accelerate a QI program, even if we're starting at 0 projects. And with the right framework, we really moved into this era of a fully engaged team leading multiple initiatives. So looking ahead, we have some practical goals for the current projects, including hopefully submitting to next year's NACFC for some of these initial projects. But we're also just very excited about what this means for the quality of care for our patients in our center. We aim to advance current projects through system-level changes, address sustainability, and integrate patients and families into our QI team. Ultimately, our goal is to build a culture of continuous improvement that enhances care for all individuals with cystic fibrosis. I want to thank our patients and families, NACFC, and the workshop session chairs for inviting me to speak, and especially wanted to thank our whole CF care team. You guys are amazing colleagues and advocates, and it's a joy to work with you.
I love that Dr. Neville brought a cheering section with her. Someone said, can you go back to your current QI slide?
Yeah, absolutely.
They may have wanted to photograph it.
Okay, no problem.
And someone asked, what do we consider a small center? And that is less than 100 patients.
There's no real definition. It was just for the purposes of this workshop that we tried to decide what was a small center. But when I've done the roundtables before, I found that sometimes people with 150 patients consider themselves a small center. So it's how you frame it as well.
Sorry, it's me again. I'm a new program coordinator, so I'm trying to take it all in. For QI, something I feel like we struggle with our team is having like those regular established meeting times, and I'm getting better at that. That's something I've been working on with my mentorship program that I've been doing with the program coordinator. But I feel like I struggle, I always feel rushed because all of my care team has other jobs besides CF.
Right.
And I'm the only 100% at 1.0 FTE. How do you establish those meeting times? Do you do it during a CF clinic day? I feel like that's where I'm struggling. I have it kind of built into CF clinic day, so then that day's really short, and then all the other days are like extremely full and like overwhelmingly busy.
Right. So previously there had been attempts at including CFQI work within our multidisciplinary meeting after our CF clinic, and it was hard to focus on QI at that point because you're addressing, again, actual patient care issues and things that are urgently needed to be addressed. And so QI kept getting kind of pushed. Yeah. So what we ended up doing is scheduling. So every center probably has their own resources. We our institution uses Microsoft Teams, and essentially we just set up a recurrent meeting. Initially, while we were getting all of these projects started, we did it weekly, just a weekly meeting until we got momentum going, and we could, like, everyone had their, we had done all the team think and like worked through to get a PDSA cycle started, or at least the process started for all the projects. And then we've spaced them out now, and so we meet monthly now for our QI work. The benefit of doing what we have found with what we do right now, we can't get through an entire, like all 7 projects every time in an in-depth manner. And so essentially if someone can't be there, that's fine. We just don't focus on their project that week. We check in, make sure that we don't need any updates. And one of the resources that we have within Microsoft Teams again, just because that's what our institution uses, is kind of a running summary of the QI work and meetings each week, so that we know if I can't be there at the next meeting, someone else has what we discussed as next steps for that project. So it is each project has its own lead. We set a time. Honestly, it's an early morning time, so people can get there or not. Yeah, or hold their first patient for clinic if we are in clinic, or yeah. Does that make sense?
Thank you.
Yeah.
Hi. Oh wow, this is loud. Sorry, not used to actually hearing my voice loud. So I'm from a clinic in upstate New York.
Okay.
We have a very similar population size and very similar travel size.
Yeah.
We don't have as many members of the team. Particularly, we've had the dietitian available over a year now. Where's your funding coming from to try to get those different people?
So some of it's from just our CF Center grants. Some of it is institutionally based, and I'm just flipping back because there we go. Really respiratory services supports the respiratory therapist. And as far as like nutrition services, that's through the nutrition department. Our physical therapist that we just had join is through the therapy, like Children's Therapy Center. So we've really had to advocate within our institution to have a CF center, which is important to the institution as a whole. We need to have these members to be able to participate. But it certainly is a struggle, and none of us just do pediatric CF care. So there are, yeah, I mean, yeah. Yeah. Right.
I think that's being addressed. So that's why
Did other people hear that? Okay.
You didn't actually hear any of what Keisha said. Keisha's our social worker on the pediatric side, and Natalie, our respiratory therapist. That's me. This came, Keisha mentioned, and I can say especially from RT, this came as feedback from our site visits, saying these are the core competence, and these are the core folks that need to be at this clinic. This is the support that the foundation is saying that you need, and we need this. I was fortunate enough to be voluntold about 15 years ago that I was joining this team, and have been able to establish presence for RT. But I would also like to point out that there are 3 of us who are shared between our adult team and our pediatric team. So our dietitian, myself, the respiratory therapist, and our pharmacist, and then our pharmacy liaison, both are all shared between the population. So I know in our institution, it started off as RT being generous, or it has now developed into an expectation of the pediatric adolescent specialty clinic and our adult specialty clinic that these are important people that need to be in these clinics. And it actually does also, our time kind of gets split between our inpatient side as well. So if folks come in, we consult with our inpatient. When the patient's inpatient, we will also consult and see the patients and provide recommendations. Does that answer your question?
I'm not sure if we got to this one. Do you find that 7 concurrent projects is too many at the same time?
Asking if it's pulling time, attention, resources in too many directions.
So I don't feel like it is, partially because this was a list of like we came up as a team and individuals. These are high priority things that impact our ability to care for these children. And so actually having them all run concurrently is nice. And especially with the setup we have where one person is the kind of lead, but we're all there helping talk through problem solving things at each of these, at each of our meetings to kind of help continue to move the process forward. So not one person is just responsible for it. But I believe it's been 7 feels good. I don't think yeah, I think more right now until we may make us a little bit more fractured. But because each person has one, as that they're helping guide continue the momentum forward, it's worked well.
If I could just add to that, I think one of the things that's really important, Dr. Neville made a good point of highlighting the level of effort, so the high impact and high effort versus high impact and lower effort. And one of the things that we really wanted to do is establish a lot of momentum, get everybody back engaged doing QI work. And the intent was to identify the high impact projects, but the ones that were not necessarily a high effort. We weren't reinventing the wheels. We weren't just trying to determine how to change a process or things like that. We're implementing established guidelines. We were working on areas where there was an identified deficit that we were kind of remediating. And so I think that helped a lot with the level of effort that goes along with that many projects.
Hi, I'm from Fort Wayne, Indiana. I'm the nurse practitioner and clinical coordinator, but I'm mostly in charge of our QI and I don't do it all, but making sure that everybody is doing their end. But I was wondering, are you collecting any quarterly metrics? I found with mine that the quarterly metrics were a good stimulus to show that, okay, yeah, we're doing a great job, keep going. Yeah. And then it was a way to check in and be like, okay, maybe we need to revise this a little bit. We're not really making the progress that we thought we would. And thirdly, I wanted to say, I don't know if you're aware of this, but on the sweat fluoride, lab has to keep their own metrics on like quantity not sufficient, et cetera. So we get a monthly report, and I have to sign off on it for lab that shows our quantity not sufficient rates. And so then I share that with the persons that are actually collecting the sweat chlorides. And that has been a good source of feedback for them.
Yeah. Thank you for those suggestions. We have not started done like specific set quarterly feedback. So that sounds like a great thing to add to our program.
Great. Yeah, thank you so much. Yeah.
I love that everyone is getting up and sharing their ideas. That's what I really liked about the roundtable format. So if we do finish early, I would love it if anybody has a really great idea that you hold on to that and maybe share it. I know I was worried that it might be hard to share ideas in this large of a format, but everybody is doing that, and we really appreciate it. So our next speaker, Cindy Brady. Some of you may have heard her speak because she speaks here prolifically. She's a pediatric nurse practitioner from St. Paul, Minneapolis, Minnesota. She's specialized in pediatric pulmonary care at Children's Respiratory and Critical Care Specialists in Minneapolis for more than 25 years. Dr. Brady co-directs the CFF-sponsored LEAP program, Leadership and Education for Advanced Practice Providers. Has everybody heard of that? Yeah, it's becoming a household word, right? It's a postgraduate training program for nurse practitioners and physician assistants in CF. And when I invited Dr. Brady to speak, I was really intrigued by her presentation on LEAP principles. And I thought, how small centers could benefit from quickly training new staff from novice to expert in an expedited and efficient manner, because who at a small center has turnover, right? Okay. And then you might put a year of your life into training someone and then they leave. So as she's speaking, I want you to think about how you may be able to use a model like LEAP in your program. Welcome, Dr. Brady. There you are. Thank you, Geraldine, Michelle. It was great to talk to you, and it's great to be here and among so many great peers. I'm going to add, I hope, to our conversation today. There's been so many themes that have come up already that I think you'll hear me say as well. So my only disclosure is that LEAP is supported by the Cystic Fibrosis Foundation. And here's my objectives for this talk. And this is just sort of a little agenda of the topics I'm hoping to cover today. And thanks for spelling out the acronym so I don't have to. So first of all, I think it's important to understand the landscape of CF care where we all live and work. Here's Seattle. Isn't that a gorgeous skyline? This is just a beautiful city. And if you live and work in Seattle at a CF center, you've got a pretty good view and you've got a lot of resources. But most of you probably feel like this. I mean, you might feel like you're the last outpost. And by nature, you don't have the same resources. But you play a vital role in providing access to care for individuals living with CF. The reality is there really is a mismatch, often geographic, between the needs of our patients, persons living with CF, and the resources available. This map illustrates this. This is pediatric pulmonologists per 100,000 children in the U.S. Now, if you look at it, the darker shaded states have higher number of pulmonologists for their population, and the lighter the color, the less resourced you are. Now, this doesn't tell the whole story because there's areas of Texas, right? Yes. That are less resourced, even though their color is okay. But there's places in Texas that aren't as well resourced as other places that tend to be in the urban areas. So this map isn't going anywhere, and it's a big reason why we have LEAP, to help fill in these gaps and improve access to care. So, you know, what happens when a center doesn't have as many resources? Well, as we've already heard, someone, probably a program coordinator, a couple of you out there, are wearing a lot of hats. And there's consequences, can be consequences of wearing too many hats. Things like poor job satisfaction, burnout, stress, anxiety, and that can lead to high turnover, which Michelle is very closely familiar with. So you kind of have to be the jack of all trades. But the first step, if you want to offload some of these hats or redistribute some of these hats to your team members or your workforce, is to really try and assess your situation. Now, I've made a very probably oversimplified hypothetical example here, but think about your center and maybe where your gaps are and where your strengths are. Hypothetically, this is just my made-up example, you might have a problem with OGTTs. Maybe you're not getting that many completed, and there's a growing patient population in your adult center that has unmet CFRD needs. Your strengths? Well, you have a very experienced seasoned nurse coordinator, and another strength is you finally got your new grad dietitian. Now, if somebody at your center is experienced in QI methods, which we've been talking about, using a little bit of a QI lens to this problem might be helpful. I'm not saying it has to be a QI project, but it does help to use these tools to take a deeper look at your gaps and maybe what your opportunities are. To a busy, overloaded, many-hatted coordinator, a strength such as a new person joining your team
may not feel that way because it may feel like another hat, somebody you have to train, like Michelle was talking about, get up to speed, and then maybe they don't have the job satisfaction to stay with it. So this is a QI tool. If you're not familiar with it, don't worry about it, but it's called a Simplified Failure Mode Effects Analysis, or SFMEA, and it's helpful for those versed in QI to identify your current process, where it's failing, and then think up interventions that you could take forward. You just saw this priority matrix on the previous talk, and this is a really helpful tool to think about your interventions and where is the low-hanging fruit. The low-hanging fruit are the low-effort, high-impact interventions. And so for my hypothetical situation, maybe it's transferring some of this OGTT to your new dietitian. Excuse me here, I've got all these notes. But remember, this dietitian's a novice. So the next step is to really think about your learner and where are they on that path from novice to expert. You want to get them to a place where they're competent. Now, most of us in the non-physician fellowship trained world in a CF center learned on the job. Do you remember that? It can take a long time. You know, we weren't on the express lane. I used to think I was a late bloomer. Well, I think I was just on the scenic route, you know. I took a very circuitous route to my competency and expert knowledge. And we're not born that way, you know. If you have a chance for the express lane, it's a structured path to competency. But most of the time, learning on the job takes 3 to 5 years. There's variable emotions, and this has all been studied. Anxiety, lack of confidence. This affects job satisfaction and retention. So thinking about this can help us think about our learner and how we can intervene and give them a better experience so they stick around. In other words, our goal is to allow our team members to be the best possible team members they can be, practice at the top of their scope, and be better. Because we all do better when we all do better. And that means our patients, you, and all of our team members. Think about where our competencies can overlap. Your dietitian, social worker, nurse, medical assistant. We all have our disciplines, but we all have overlap. And some of these skills or competencies can overlap, and somebody may have a better predilection for one type of competency or another. Things like scientific knowledge, quality. I mean, look at all the leaders in quality in Missouri. This is just fantastic. But there's other skills: leadership, communication, patient partnership. And your team members, if you have a chance to form your team or select team members, think about certain qualities that may make a successful team member. It may be more important than a shiny resume from a prestigious university and a very straight career path. But a successful team member might be someone who's curious, who's motivated, who likes to play on a team, and someone who's scrappy. What does scrappy mean? Well, it might mean that they've taken that scenic route and pieced things together, worked hard. Maybe they started off as a MA and went back to school and have maybe held various jobs, but have worked hard to get to the place they are. So this brings us to, once you've kind of figured out your gaps and your team members, now you can think about what we did with LEAP and how you can apply this to your learner. This is our LEAP engine, the kind of 3 components of LEAP: The first was a curriculum. We built a comprehensive soup to nuts, A to Z CF curriculum. We paired that with mentoring, so mentoring both clinically and professionally. So every LEAP fellow had a clinical mentor in their home CF center, and they had a professional mentor, someone who's a seasoned APP in the greater CF community. And then finally, our LEAP fellows all completed and led a quality improvement project at their home center, and we had leadership curriculum sort of sprinkled throughout. This last component, the quality and leadership, may be better suited to someone who's already achieved competency in their discipline, whether it's a dietitian, social worker, respiratory therapist. So something to think about. So here's some lessons learned from LEAP that I'm hoping you can find a couple of these and take them home. Number one is don't reinvent the wheel. I think we already heard that today. There's a lot of things out there. Don't reinvent the curriculum. It's invented. I've got resources for you. But spend your time inventing relationships or creating connections. My dad sold real estate, and if you were a buyer, he emphasized 3 things in real estate for a piece of property: location, location, location. I'm going to tell you, in our business, it's about relationships, relationships, relationships. And already here today, from Argentina to Missouri and everywhere in between, people have already made connections and strong relationships. There's a lot of resources out there to connect with, and I even like the idea of, someone having a pharmacist take on and building a relationship with a pharmacy benefit plan. I mean, that's the ultimate, right? If you can have them on speed dial, that's great. But the same is true for all of these relationships. There's regional core centers around. They're well-resourced. There's people there you can get to know. PEP, quality improvement resources through CFF, the CFLN. There's discipline groups. There's all kinds of places where you can build these relationships and get the expertise you need. Your institution may also have resources, as we already chatted about, and perhaps even local academic institutions like a nearby school of nursing or healthcare academic institution. One thing I really want to highlight and have you think about making good use of is the Indiana University's CF courses. They're all individually paced online modules. They've done a fantastic job. They've really come into their own in the last few years. Their offerings are more and more comprehensive all the time. I just can't say enough about them. We used them in LEAP. The nice thing is they have all the experts writing these. They're updated regularly, so they're fresh. They just recently took down a GI course because it needs to be reworked because of all the effects of HEMTs. So check these out, and I'll have a barcode, another one to scan at the end of this. They're free, available to anyone, and you get continuing ed credits. One of the biggest things with LEAP that our fellows talk again and again about is case-based discussions. So taking that online learning and making it real with live discussions. We met synchronously, is what it's called, and had discussion groups. We would bring in an expert on the topic, and then fellows would present a case to the expert for discussion. This was a great model, and I think really made learning real and applicable. You may not have these big opportunities to pull in these experts, but ask them. All of the authors on these IU courses have been great. We've asked them to join us on our LEAP sessions, and we've never had anybody turn us down. You can do it smaller, too. Find a time in your regular team meeting and have your learner present a case and discuss it. Not only does it help everyone learn, but it boosts their confidence and ability to manage patients and presentation skills. So these have been a really important aspect. Mentoring, this is another place where you're not born a mentor. Having some structure around mentoring is really ideal. There's resources out there if you're a mentor. The 1-minute mentor is something we used with LEAP to support our mentors, our clinical mentors. I won't go into this, but this is a pretty simple structure to follow, and it's very available. One last thing we learned is you really needed your institutional support, and by that I can mean CFF, but also your home institution, as you've been hearing. It's essential for success. One way to sell it is your return on investment, creative use of your strengths, and find a champion to go to bat for you. So the return on investment, these are sort of the subjective returns on investment that our fellows report: confidence, connections, leaderships. But the stuff the bean counters are going to worry about is the objective data. As you can see, the competencies in the graph on the right really improved. These people are on the expressway, not the scenic route. 82% are still active in CF care. They're practicing at full scope. They have high job satisfaction and intend to stay in CF. And with that, I'll take some questions. I just want you to think about your little outpost and realize that sometimes you actually may have the best view. And like the Northern Lights or the Aurora Borealis, it's only possible to see it if you're in a remote location. So thank you. Thank you.
Any questions?
Which? The previous one? Oh, okay. I go back. Oh, oops. Sorry. You wanted those resources, correct? Yeah, sorry. Here. That one.
That one, yeah.
And they're links, but I can post a handout as well.
Dr. Brady, do you feel like APPs in the larger centers are the main ones taking advantage of your program, or do you feel like APPs from smaller centers are also taking advantage of the LEAP program?
We've had a mix, actually. It's been fairly balanced, and I think when I looked at some data about a year ago, I think we were equally represented by small and large centers, depending on how you define small or large centers. But some of the biggest, most impressive QI projects have come from people in small centers who have made connections to bigger centers or been scrappy.
We understand scrappy. It seems like sometimes you're always trying to save your center from drowning, and so you do have to be scrappy and resourceful.
Right.
Any other questions for Dr. Brady?
Thank you, Dr. Brady.
Thank you.
Okay, so rounding out this workshop, we have two speakers, and we were very impressed by their scrappiness, stealing the word, using it. But really, they're going to give you real-life examples of their small center strategies for overcoming all of the challenges that they face. Denise Gillum is a certified pediatric nurse practitioner working with pulmonary, critical care, and cystic fibrosis patients at Parkview Regional Medical Center in Fort Wayne, Indiana. With over 30 years' experience, Denise has an avid interest in quality improvement and is a champion for small center success. And Denise loves to walk, so she can walk on up here. Oops. Yeah.
Hello, everyone. I am Denise Gilham. I'm from Parkview Regional Medical Center, which is a center in Indiana. I do not have any disclosures. We have 54 pediatric patients. There are 2 CF centers in Indiana. There's a core center, Riley Children's Hospital, and then our center is an affiliate center. Our team consists of a pediatric pulmonologist, 1 pediatric NP, myself, 2 RNs, 1 dietitian, 1 mental health /social worker because she does both roles, and 3 respiratory therapists. We do have access to pediatric subspecialists, and that is infectious disease, endocrinology, GI, cardiology, neurology, and pediatric general surgery. I do believe there are advantages to being in a smaller center. One of those is that we are located outside of the larger CF center, and we are typically easier and less time consuming, as we've heard over and over again, for patients and families to utilize. I feel too that often parents and patients feel more comfortable accessing and receiving inpatient and outpatient care within their local community. And primary care providers find local centers easier to access, communicate to, and work collaboratively with. We have a great relationship with the primary care providers of all of our patients. They know that they can call us at any time. They utilize Epic Chat a lot, and when they have any questions, they know that we are readily available. Our local team also has more knowledge of community resources that are available to the families locally. We do provide collaborative management of our CF patients. Honestly, very few patients use this opportunity, but we do have a few that do. And we've noticed that with decreased number of visits post-HEM, meeting the CF guidelines is currently more difficult. So not having a nice shared care model is really very effective. So we do shared care with our core center for a small set of our patients, meaning that if they want to access the core center, they can access the core center, but they can still receive care locally as well. Sometimes, especially with initial diagnosis, the families may desire or need a second opinion, sometimes especially with the more complex mutations. Patients will see the larger centers typically 1 time a year, and then will come to our local smaller clinic for the other 3. It's nice because they're able to meet complex services that we do not have. For example, they have a pediatric GI that specializes in CF. We do have access to pediatric GI, but they do not specifically specialize in CF. But then they can still have the local team as their home base to come back to for routine testing. Also, we do not have research studies available within our smaller center, and so they use the large center a lot for access to research studies. We also do collaborative management of CF through our CF newborn screen program within Indiana. Indiana is divided into regions based on geographic proximity, meaning that if the abnormal newborn screen, we are in the northern part of Indiana, is closer for the patient to access, and then we receive the abnormal newborn screen. If they're in the mid to southern part of the state, then Riley receives it. And what that means is then that we're responsible for ensuring the diagnostic testing is completed, submitting a genetics referral, which is typically telehealth for us, and then subsequent care if sweat chloride is abnormal. We do give them the option. They don't have to, just because we process the abnormal newborn screen. They can choose between either our center or Riley. It's really up to the family. We give them the option. Thus far, our abnormal newborn screen has processed, meaning ours in Fort Wayne, 17 CF positive cases, which were 2 mutations, 138 CF positive for 1 mutation, and 21 increased IRTs. And we do sweat all of our IRTs. Trials and tribulations. So right smack dab in the middle of COVID, we lost support from a community hospital where we were previously located for a pediatric CF program. We do have a large Amish population who have difficulty traveling a distance for care, so for them to travel to the middle of the state was going to prove very difficult. So myself and the CF pulmonologist, we approached the other community hospital, there's basically 2 within our area, about bringing the CF program to Parkview Regional Medical Center. We basically cried and pleaded and did everything we possibly could to convince them that this was not fair to the CF population that was already within Fort Wayne. They did recognize the importance of local care for the CF population, and they were willing to assume the salaries of the providers and the clinic team without grant support in the first year. So trials and tribulations, the financials, which are always a difficult part for small centers. We did utilize a local foundation to purchase sweat chloride testing equipment, and that was very beneficial. It took us about 6 months to receive that funding, to get the machine purchased, and then to get everyone trained. So we did try a LabCorp. I don't know if everybody's familiar with that model, but it wasn't really very effective, and the quantity not sufficient rate was really high. We also used CFF grant monies to offset cost of team. We deferred conference attendance the first year to provide additional salary support in the first year, and we did have approval from CFF to do that. We applied and received the mental health and pharmacy grant year 2, and that has continued. And then we worked with IDOH and Newborn Screen Lab and received a grant for CF abnormal screens in the state of Indiana. That being said, we've received just under $1 million in grant funds in 5 years, and that's a combination of CFF, state grants, and local foundations to support our program. Education, the clinical coordinator and myself at that time provided training and resources for CF clinic staff, lab, ancillary departments, and inpatient staff. We provided education for and trained the HOD staff to complete sweat chloride testing. We had tried the lab model, but it wasn't very effective due to the frequent turnover rate of staff in the lab, and then also just their availability in order to complete the sweat chloride, because it is a lengthy test, as we all know. We worked with lab. We had glucose tolerance, but it was not in the 2-hour format, so we had to work with them on that. And then we also had to develop and implement CF cultures. We worked with the EPIC team to set up basically everything for CF within EPIC, so the testing, codes for sweat chloride, CF culture, the 2-hour glucose tolerance as opposed to I think it's a 1 hour, and then ordering and resulting those as well in the system. We worked with infectious disease to develop and implement outpatient and inpatient infectious disease practices. And we used the CFF resources for training new team members. So basically, for nutrition, RT, social work, and pharmacy, the first day of clinic, and well, maybe a little bit before that, because we did have some meetings beforehand, you got the CF training program for your particular discipline. And I said, this is your Bible. Any questions, let me know. And you need to carry this with you at all times. And it is a very, very valuable resource tool. So we did have success. So our current 2024 glucose tolerance completion rate is 91.3% versus the national average of 45.2%. Our one culture, one visit, one PFT completion rate is 100% versus 94.1%. Our fat-soluble vitamin measurements are at 100% versus 94.1%. Our average cultures per year are 3.6 versus 2.8. And our visits with the mental health worker, dietitian, and respiratory are 100% versus 91, 88, and 54 respectively. And then our influenza vaccine rate is 90.9 versus 70.8. And not to brag, but I think that's a little bit remarkable because 25% of our population is Amish who don't believe in influenza vaccine, but we preach and preach and preach about the importance. I also wanted to say that a lot of this came from PI or QI, that they were ones that we weren't performing well on national metrics. And so we looked at it, performed a PI, and then changed our practice, and then this was our result. You can see, this is not a very good slide in the fact that you can't see it, but you can open it up later. We are a small center, but I do think we're very effective, and I do think we provide very good care. A lot of our metrics are either above the national standard, at the national standard, or just slightly below the national standard. And again, we do all of our PI and QI pretty much from our specific report. We typically identify the top 2 things that we're not performing well in, and then we develop a PI based on that. And we have always done that, even when we were at the hospital before. This has always been our guide for our PI QI. Our quantity not sufficient rates, I know this is a hot topic on the listserv, so I kind of wanted to speak to this. The first year was 2021. Our total quantity not sufficient rate was 23%, and our N was 73 at that time. Our rate for less than 3 months was 31%, which is abysmal, and then our greater than 3 months was 8.5. So we did a PI, of course, and we implemented a patient education for hydration. The family gets this whenever they schedule their appointment, and then somebody calls and touches base with them when they remind them of their appointment. They go over the hydration protocol at that point in time. We also, which I mentioned, moved sweat chloride testing from the HOD, to the HOD from the lab. Anybody that does sweat chloride testing has to do an annual competency to demonstrate proficiency. And then we developed the saran wrap, warm blanket, and warm room method, meaning that at the collection site, we wrap saran wrap around that. We lay a warm blanket on top of that. And then we tell the parents to dress the kid warm, but they dress cool because the room's going to be at least 75 degrees. Our QNS rate improved significantly. In 2024, our total rate was decreased to 5%, and our N was 124. Our less than 3 month quantity not sufficient rate went to 4%, and our greater than 3 month went to 5%. I wanted to show this map. I don't know if you're all familiar with this, but sometimes I do think that as an affiliate center, we feel like we're not important, and that not that we're not important, but that we don't have as much impact. But this is a map of all the CF centers, right? And I don't know if you all are aware or not, but there are 54 affiliate centers that comprise all the affiliate centers in the US. And I wanted to do something magical, but I'm not technologically savvy, so I could not do it. So you're just gonna have to imagine it in your brain. The light circles are the core centers, the dark circles are the affiliate centers. Just imagine in your mind if 1/3 of these centers disappeared. That's what we comprise. And what the accessibility to care would look like for our CF patients. It would be a very big impact. So I just want everybody to know that you are important. We have our struggles. You do have to be scrappy. You have to beg, borrow, and steal, but it is very important to our patient population. And in conclusion, as the CF population continues to age and early diagnosis becomes increasingly critical, there is a growing need for easier and more equitable access to care, including diagnostic, surveillance, and preventative practice. With a robust collaborative network between core centers, affiliate centers, departments of health, state newborn screening programs, we can provide the convenience patients need without compromising the quality of care. And this is our team.
Oh, we have the second half to this time slot. This will be our last speaker, and so we appreciate everyone hanging in there. These two ladies shared the Triumph slot.
Yes, I'm introducing Wendy Tague. She has been the CF nurse coordinator for Children's Hospital of Michigan in Detroit since 2014 and has enjoyed the personal interactions with the patients, families, and the whole CF community ever since. And Wendy's fun fact is that she is also passionate about eliminating food insecurity. She heads up her hospital's food drive, and she also has a garden and donates the things she grows to the local food bank. And here's Wendy.
As she said, my name is Wendy. I am the CF nurse coordinator for Children's Hospital Michigan. I have no disclosures. So as many of us are here, we're part of small CF centers. And the benefit to a small CF center is, like, we see that our patients have access to care challenges. In the small centers, they play an important role in improving that access to care for our patients of CF. Small CF centers can fill access gaps in a lot of different communities, in rural settings, in urban settings, and in urban settings like my center. As I said, our center is in an urban community. We're located in the center of Detroit. We currently have 98 patients ranging from age 2 months to 21 years of age. We have a strong affiliation with our adult center at Harper University Hospital, right across the street from us, or across the courtyard. Our Children's Hospital of Michigan is a large pediatric urban hospital. They are also part of a very large Detroit Medical Center that services all of Metro Detroit. So it's really easy to feel like a very small center, even within our own healthcare system. We do have some very unique challenges in being a small center in a large healthcare network. Operational costs for small centers can be greater than the revenue that we produce for our hospital systems. With the use of effective modulator therapies, hospital admissions are down, and therefore revenue for that is down. Staffing for small centers can be very challenging because it is very expensive to staff all of us and our salaries. Providing the little extras that CF care centers, that's kind of unique to a CF care center, can be challenging to fund as well. Some of our strategies for operational challenges. So the operational costs, like I said, we oftentimes don't generate the same revenue for our hospital systems. So we have strategized to meet with our hospital grants officers to discuss budgeting a few times a year. We discuss what's available in our CF Center grant and other grants that we apply for. We meet with our hospital administrators at least annually, probably more frequently than that, to remind them of maintaining the CF Center and how much it means for our healthcare center, for our hospital. We review our annual center reports with our hospital administrators to show them that we are meeting benchmarks, and in areas that we aren't, that we need some more support to help pay for that. And we share costs of supplies with other departments when we need to. For staffing strategies, as we know, some of the minimal staffing for CF centers are the CF director, the associate director, center coordinators, dietitians, social workers. And then there's some other staff recommendations like PharmD, mental health, GI, endodiabetes. So what we have done is we looked at our CF grant, and we know that portions of the grant pay for portions of their salary. Our dietitian, we pay for part of it, and she also is covering an inpatient unit, so the dietitian or nutrition department covers the rest of her salary. Excuse me. Our social worker is also our mental health coordinator, fully licensed, so that was a win. Our social worker is part of her salary is out of our CF grant. The other part is shared with the social work department, and she covers immunology and diabetes. And that kind of made sense because of the CFRD. So putting her with that clinic was a logical decision. Our research nurse is also our registry coordinator, and her salary is half and half CF grant and department. And our respiratory therapists, all of their salaries are part of the RT department, but they do have to cover a few clinics in our ambulatory setting, pulmonary, CF, allergy, and they also perform all of our sweat tests. I am the CF coordinator. I'm also the newborn screening coordinator, the CF nurse. I'm in clinic with all of my patients, manage all the insurance auths, schedule all the newborn screens, and then I do take on some of the more complex pulmonary patients just because, you know, as a coordinator, we kind of learn how to do that. We do not have a pharmacist in our core group, but we have worked out with our pharmacy team in the hospital that they provide a pharmacist to evaluate our patients' medication profiles annually. They give us updates on or answer any questions about drug interactions, dosing for antibiotics, and they're kind of like on call for me. We don't have an endocrinologist with our team, but we do have one that's assigned from our endocrine department. She runs a clinic that runs at the same time as one of our CF days. And so we do coordinate those care visits for our patients so they make less visits to the office. We also don't have GI on our team, but we share the same office space, so that kind of makes it nice for us to do sidebar kind of referrals and questions and talk about cases. And for some of the little extras that the CF Care centers provide, family education night. We've had real low outcomes, like attendance by our families, so we're kind of revamping that. It's a high dollar amount, so do we really need to put all of our money into a CF education night? So we're going to look at doing an open house instead, providing like some of the education there, but also providing a lot of the education in a biannual newsletter, which we're hoping to have that established by January. We also have QI projects going on, and some of that needed budgeting as well. Our QNS rate was high, and so we petitioned leadership for some large dollar amounts like a blanket warmer and signage in our offices to promote flu vaccines, which we were successful. They covered it for us. Hooray. Sorry. It was a big win for me. So some of the other extras is attendance to NACFC. So once all the salaries are paid out of our center grant, then we have to look at who and how do we get people to NACFC. It doesn't cover everything. So we have a great social worker. She loves writing grants, and she writes a lot of our grants for us. And so we do tap into local nonprofit organizations that like to help promote education in the CF community and patient care, and they help with travel expenses for us. We've also partnered with a local nonprofit organization to establish a patient-parent mentoring program, which has been pretty successful. I think we have 5 patients or families enrolled this past year with pretty good feedback from them. And we also have a project to help ease procedural trauma. Again, our social worker is fantastic. She wrote the grant for it, and we do poke prizes. So they're not quite so scared. We have the poke prizes ready for them. They can look at it while we're doing lab draws for those modulators. So there is a continued need for the small CF center. So like, we need to stick together, and in the current healthcare model, small centers can be easily overlooked because we maybe aren't as profitable. But outside of that, we can function as middlemen for providing ancillary service for the large centers. We can also provide access to CF care by providing personal care in a more, in a variety of settings, like the urban and the rural settings. And we also, as a small CF center, we all strive to provide the same level of care, but we just have to be a little more creative and flexible in order to deliver that kind of care, so that, you know, budget-wise, we can meet all of those guidelines. That's all I have on how we've been creative in managing our challenges.
That's great.
Anybody need to ask any questions?
We have a few from the app. Anybody standing up? Let's see, where should we start? Who in your center does the education? This is for maybe for both of you, because you both talked about sweat chloride, but who in your center does the education for sweat chloride testing? Is it nursing? How are parents identified of abnormal newborn screens, and what the process is for scheduling sweat testing?
Well, in my area, newborn screens are disseminated to the CF centers. They also go to the physicians, the primary care doctors. Sometimes they get that initial call from the primary care doctor. Sometimes it's from me. And then I explain the process of sweat testing, genetic counseling on the same day. They do get an email also that kind of reinforces all of the things that I've explained to them on the phone, because sometimes you're kind of in a panic, and being able to read it later when you calm down helps a little bit. And then our genetics kind of give them the test results, as well as genetic counseling the same day after the sweat test. So that's that's our process.
And then you want to talk to the training more? How did you?
The training for the HRD staff?
Yeah.
For the sweat testing?
Yeah. Okay.
Okay, so we purchased the MacroDuct system. And with the purchase of the MacroDuct system, they were willing to provide training on the system. And so at the time, it was not in the HOD and the lab could not come up. So myself, the RN, and 2 RNs at the time were trained on it. And so for a little while, a very short time, we were actually doing it in conjunction with the CF visit, but we needed to push it over to the lab so we could actually bill for it because we weren't able to bill where we were. So then myself, the 2 RNs, then trained the HOD staff, developed the competencies, and they had to demonstrate proficiency. And then as I was speaking to, as far as like the quarterly metrics on the quantity not sufficient metrics, I can get those monthly from the lab. And maybe this sounds like punishment wise, but it wasn't. We would look at each individual person has their own metric on if they are, what their quantity not sufficient sample looks like. So then if we had somebody that had a relatively high quantity not sufficient collection rate, then we would go back and remediate with them and retrain.
Okay. Another question from the app. Can you elaborate on the process used to work with Epic to set things to set up things for the CF OGTT? And I feel like learning from you guys, if you need something, ask, because I always assume at my institution that the Epic builders are just way too busy, and my request would be at the bottom of a 50 pile up. Yeah.
So basically, I asked to be assigned to one Epic developer, and he became my best friend. And so every time, I will say this, like, I guess I'm kind of scrappy because I basically had 6 months if I wanted to have them not have to go to Indianapolis to get the clinic up and managing. And so I just said to myself, this does not have to be perfect from the start, right? This is a clinic in process, right? And our basic goal at the beginning was to provide care to the patients, and it would be good quality care, and we would just figure it out from there. And so the Epic things kind of came along too. That was not a high priority for me, because basically my RN Pam is over there, but she did not join me for 3 months. So I was on my own doing all this, and I was like, my family never ate. So we just developed these things. So I just started with the most important thing, in our opinion, was the sweat chloride testing. I wanted that up and functional so patients could have a good quality sweat test. The CF cultures, we sent those to LabCorp for a period of time. It was a horrible process. It did not work, but we just kind of made the best of it until we got it up in Epic. And then the glucose tolerance, I worked with the lab, and I would just go down to the lab and actually meet them and just, again, ask for their sympathy. And so they only had the 1 hour built in it. So they came up with a runaround that we did a glucose tolerance, but they did but then I just entered a glucose, and then they resulted that at hour 2. And we did that until it could get built in Epic. So I guess my thing is that we just continually were like, okay, this is a roadblock. What can we do? Let's think outside the box. You show up in an office of whoever you need, whether it's Epic or lab or whoever, and say, this is what I need. What can we do? How can you help me? And it seemed to kind of fall in place.
And we might go over a little bit, but looks like there's a couple other questions.
Sorry.
No.
Hi, my name is Quinn, and I'm with the CF Foundation. And so I get to work with, or rather hear from a lot of adult patients and their families about what makes their CF care unique, and the relationships comes out frequently. I'm interested in both of your experiences with regards to retention of your team members. What does that retention rate look like, given how scrappy you had to be in pulling and keeping people together?
We have a great core team that have been established for quite some time. Probably the newest member of our team is our social worker, and she's been there 5 years. We don't have a lot of turnover, and I think a lot of it comes from the fact that we just really enjoy the relationships of our patients. We like the CF community, and we just really don't want to change. I personally worked previously inpatient on the CF unit and then transitioned to this role 10 years ago. So it was always kind of in my heart, the CF thing. Same with like our RTs and our dietitian. They've always just been in as part of our team.
I can answer this.
So one more live question, and then
Thank you for your experiences. I wonder if we could have like a the CF Foundation could set up like a small center support group or something.
I have been thinking of that. I wanted to approach Paula with that. So
Because
that a small
I think we all
get-together.
deal with so many similar issues, and it's kind of insulting in a way that we have to be scrappy. I just wish there could be more resources like provided. I don't know if you could take that back to the powers that be, but I feel like if it's so important that we provide care in their local areas and we provide this excellent care, I mean, it's just very difficult, especially in today's climate, to maintain. So I would just advocate for that. And I love the idea of a support group. We have one for the TDN where we meet with, regional centers and we go over like how we can refer patients for research studies. So it'd be like a similar model because I think all the stuff we do is so important. So thank you for your efforts.
We can work on that. And then the last question, it's a little bit difficult to answer, but someone asked to explain the differences between a core center and an affiliate center. There is a document through the CF Foundation that describes the differences. And it has to do with number of patients, what specialties you have available, but there is a document that delineates it very clearly. And if anybody wants to come talk to me afterwards, I'll give you my email and I can help get you that document.
Can I speak to the core center on affiliate center? We actually were approached to become a core center, but the heart of our center has always been good quality clinic care. And our team is small. And we felt like if we became a core center, it was going to be using our resources that we wanted to keep and dedicate it to quality care. And so we opted not to become a core center. We knew that we could get more funds, but we really felt it would pull us away from our primary care guidelines, and so we declined.
You guys, sorry. I just want to thank our speakers so much for all of the hard work that they put into this workshop. Thanks to our group that traveled all the way from Argentina. Thank you, Geraldine. Do you have anything else?
No, took the words right out of my mouth. Just wanting to thank everybody involved. It's been a great
Y'all have a great day. We're finishing right on time.
Thank you.